Good afternoon, everyone. My name is C.B. Mamaril, and on behalf of the Systems for Action National Program Office here at the University of Kentucky, I'd like to welcome everyone to today's PHSSR Research and Progress webinar, focusing on the cost, quality, and value of public health services. We have a great topic for us today, which is assessing the impact of economic recession on public health outcomes, exploring new methods and measures. And before we get started, I'd like to remind everyone that today's presentation and speaker bios are available for download if you take a look at the resource box in the top right corner of the screen. And during the presentation, you can also type in your questions at the chat box at the lower right corner of your screen. So for those who are new to these webinar series, usually the flow of the webinar is I introduce our presenters first, and then they will be giving their presentation. Afterwards, I will be introducing the commentators, who will then give their commentaries, and then we give the presenters some time to respond to the comments. And then if we have time at the end of the webinar, we open the webinar or the presentation to questions to the audience. And so with that, it is my pleasure to introduce our presenters for today's webinar, starting with our first presenter, Dr. Anna Schenck, who directs the Public Health Leadership Program in the North Carolina Institute for Public Health at the UNC Gillings School of Global Public Health, where she is also professor of the practice and associate dean for public health practice. She holds a doctorate in epidemiology and a master's degree in public health education, both from the University of North Carolina at Chapel Hill. Anna is an interventionist epidemiologist who works to identify and use data to improve the health of the public. Prior to joining UNC, Dr. Schenck worked with the Quality Improvement Organization for North and South Carolina, working to improve the systems, processes, and outcomes for Medicare enrollees. While at QIO, Anna led 2 national projects to develop quality measures for colorectal cancer screening and hospice care, and has worked in a local health department as a health educator and as an epidemiologist. And she has extensive experience in measure development and assessing the scientific soundness of measures. Dr. Schenck has served on national measurement panels, including the Cancer Data and Methods Panel for the National Quality Forum, the Expert Work Group for Clinician-Level Measures for Palliative Care, sponsored by NCQA, and the National Health Security and Preparedness Index Model Design Group. Anna also chairs the Scientific Advisory Committee for the America's Health Ranking. Our second presenter would be Dr. Anne-Marie Meyer, who is an epidemiologist who focuses on interdisciplinary methods for leveraging large real-world and observational data for public health and outcomes research. As director of the Integrated Cancer Information Surveillance System, Anne leads the development of a big data research platform, which combines data from the State Cancer Registry, multiple payers, epidemiologic cohorts, medical records, census, and other ecological data sources. Using a team science approach, the ICIS team is developing novel methods to help identify, organize, manage, and use big data in order to make the data more accessible to patients, clinicians, researchers, and public health practitioners. Dr. Meyer is an assistant professor in the Department of Epidemiology at UNC Gillings School of Public Health, and is also a member of the Lineberger Cancer Center, research fellow at the Shep Center for Health Services Research, and a faculty member of the Carolina Health Informatics program. So with that, I'd like to turn it over to Anna and Anne.
Thank you, CB. We're very excited to be here to share with the audience the research we've been working on, and hopefully that will lead to a conversation about some of the challenges that we've encountered and some possible solutions to those challenges. So I'm Anna, and I'm going to start off the presentation. The title of our presentation is New Methods and Measures to Assess the Impact of the Economic Recession on Public Health Outcomes. So I'll provide a little bit of background about the study and some of our methods, as well as talk about the results we found in terms of mortality, and then I will turn it over to Anne-Marie. So we know that we're facing a lot of challenges in public health today. Local health departments are being asked to justify the value of the programs and services. And this calls out for new data sources and methods that can help them do the type of measurement they need to do. So our study was exploring not only how to demonstrate the value of public health services in traditional ways, but also to explore the development of new methods and measures that could help justify the programs and services of local health departments. We did our study in North Carolina for a couple of reasons. Yes, that's where we're located, but also North Carolina was particularly hard hit by the recession. And we had comments from our local health directors imploring us to help them come up with ways to measure their value. So these comments that I've got on this slide actually are direct quotes from a session we held with local health directors. Can you help us evaluate the work we do and measure return on investment and health outcomes? Or what we need is a cost-benefit analysis, information on how to save money and still have impact. Local health departments need help communicating the value of what we do. Or we need to create a better understanding of the definition of value added of governmental public health. So these are their issues that are facing them every day, and we were hoping to add to the body of knowledge and the work that had already been done to see if we couldn't help in this arena. But deciding to do that opens up a number of options. So how do you measure value? There are three sort of categories of approaches that are typically used. One could approach it from a cost-benefit analysis, which would ask the question, are the benefits greater than the cost? This would require that the benefits be translated into dollar amounts. Or you could ask it from a cost-effectiveness approach, which would ask the question, what is the cost per unit of outcome? And in that type of analysis, outcomes would be measured in units that were appropriate to the condition targeted. Or you could approach it from a cost-utility approach. So what is the cost per standard unit of outcome? And in that case, the outcomes would be measured in a standard unit, such as the quality adjusted life years. But the bottom line on all of these approaches is that you need to have good measures of cost and good measures of outcomes. And so those are the two things that we were trying to focus on, particularly the outcomes. So prior to embarking on the study, a lot of work had already been done, and we were able to build on that. So we know from past research that local public health spending was shown to be associated with local health department performance of essential services and improved community health outcomes. We also knew that the economic recession in 2008 resulted in decreased funding for local health departments. So that set up the question that if more spending meant better performance and improved health outcomes, was the opposite true? So that when local health departments saw decreased spending, were their health outcomes worse? So we examined the impact of reductions in local health department spending, staffing, and services on community health outcomes. We had two overarching aims. The first was, in the context of the economic recession, we wanted to look at the relationship first between public health spending, staffing, and the provision of services, and then secondly, between spending, staffing, and services and health outcomes. And the second overarching aim was to develop and examine the feasibility and responsiveness of new measures of population health to respond to changes in public health services. We took advantage of the natural experiment that was occurring all around us with the recession, and we followed North Carolina local health departments from 2005 to 2010. In North Carolina, there are 100 counties, but we have 85 local health departments that serve those 100 counties. We tapped into a number of different sources of data. The National Association of County and City Health Officials, or the NACCHO profiles, we used two of those, the one from 2005 and 2008. We used data from CDC and North Carolina on mortality and population-based data for the entire period. And we also used a novel data resource that we had in North Carolina, the Integrated Cancer Information and Surveillance System, which contains health insurance claims. And the data from that system went from 2005 to 2010 as well. Just a little bit about how we measured spending, staffing, and services. So these measures all came from the NACCHO profiles. Spending was captured using the expenditure data that was reported on the profile survey from the most recent fiscal year. And in our analyses, we express this as the dollars per capita based on the service delivery area of the local health department. For staffing, we included full-time, part-time, and contractual employees, and also expressed this as full-time equivalents per jurisdictional population. For services, we measured them following the approach that was used by Mays and Smith in their 2009 article. And we looked at them in two ways. One, as a percent of total services in that particular category that could be offered, but also looking at whether individual services were provided and was there an effect of an individual service. Our measures for health outcomes were calculated separately for each outcome for the service delivery of the local health department for two separate time periods. And we used 3 years of data for each time period. We had 2005 to 2007, which we were considering our pre-recession data, and then from 2008 to 2010 to capture the effects of the recession. We had, in terms of outcomes, we did both mortality and morbidity and prevention outcomes. The mortality outcomes, there were 5. We looked at using national vital statistics and ICD-9 codes: cancer, heart disease, diabetes, influenza, and infant mortality. And morbidity and prevention measures, we added these because we wanted to try to get a more proximal indicator of the services of the local health departments. So we constructed indicators of illness and preventive behaviors using published or code sets that we had to create. And we looked at hospitalizations for heart disease, cancer, diabetes, and influenza. We looked at outpatient care for reportable conditions, things that health departments typically work on, such as sexually transmitted diseases and foodborne illnesses. And then we also looked at mammography and colorectal cancer test use using age and sex appropriate denominators. So about the novel data source, Integrated Cancer Information Surveillance System. This was initially developed to study cancer in North Carolina, but the data are not limited to cancer cases or cancer treatment. It includes data on all persons enrolled in the participating insurance plans, and it includes information for all services those enrollees receive. It contains administrative and claims data for North Carolina residents covered under Medicare, Medicaid, and private insurance plans, and represents 65% of the North Carolina population. In our analytic approach, we use multi-level models that incorporated the time element of the data. So every local health department had 2 points in time. And we explored geographic variation of each exposure and outcome. So now just a little bit about our results. We've set up the methods. Let's talk about results. So we did observe in terms of spending a very wide variation across local health departments. So the range went from $35 per capita to $218 per capita. And in the aggregate, spending increased between the two time periods of 2005 to 2008. So this is important because we knew that we were probably going to be at the early end of, the very early beginning of the recession with using 2008 as an endpoint, but those were the data that were available at the time. So we went with that. But in the aggregate, we saw an increase. However, we did see pockets of the recession hitting first. So 10 local health departments did have a decrease in spending, and all 10 of those actually were in some of our rural areas. So we also observed that higher spending was associated with increased staffing, measured as full-time equivalents, and increased provision of selected services like medical care and specialty care. In terms of the results related to staffing, we also saw wide variation across local health departments. And in the aggregate, staffing decreased between 2005 and 2008. So we were beginning to see the effects of the recession. 36 of the 85 local health departments had fewer staff in 2008 than they did in 2005. In terms of services, again, there was a wide variation in the types and levels of services that were provided, although there were some things that were nearly universal. So almost all provided high levels of clinical preventive services. But some of the services that were not as complete in their provision were environmental services and home health services, where we saw more variation. In terms of our mortality results, spending was not associated with any of the mortality outcomes we examined. Staffing was associated with infant mortality. Specifically, increased FTE staffing was associated with decreased infant mortality. And the provision of medical treatment services was associated with decreased infant mortality. And when we drilled down to see what particular medical treatment services that were important, two services stood out as being significantly associated with reduced infant mortality, and that is prenatal care and OB care. One of the things that our locals pushed us to do was to translate this for them. How does this make sense? How can we use this to describe the benefit of what we're providing? And so if you take the findings that we had and turn them into a live saved calculation, what we find is that they imply that the provision of services by local health departments in the year 2008 may have resulted in between 100 and 200 fewer infant deaths. So I'm going to turn it over now to my colleague, Dr. Meyer, and let her continue talking about some of the novel things that we were exploring.
Thank you, Anna. So we wanted to develop this question about, can we measure more proximal outcomes that might be associated and more sensitive to local health department capacity of spending and services? So we wanted to see if we could identify morbidity outcomes that could be measured at the local health department level and take advantage of this era of big data, where we've been able to link disparate data sets together, and these can be aggregated. They can be measured at individual levels, or they can be measured at levels of local health departments and then brought together under a jurisdiction. And there's a large number of new resources that might be useful for public health services research, including the PCORNet initiative, or all payer claims databases, or even some commercial large databases are actually quite informative potentially for public health practice. But with these new data sets comes some significant new challenges, and we really need novel analytic methods to figure out how to use these data well for the questions that are relevant for public health practice. Specifically, it's really challenging with these data sets to figure out what the sampling frame or what the denominator, to be confident that we've enumerated the denominator for the observation or jurisdiction that we're looking at. Additionally, the observations of the data sometimes are ecologically connected, where they're sharing a measure that's not necessarily measured equally across individuals, or it's measured at an observational level, or then it's measured at a higher level and inferred onto observations. And crucially, oftentimes the observations are not independent in the data set, and we have a lot of challenges with dealing with that because that's a major assumption under epidemiologic and biostatistical models. So the first thing we wanted to do is really see if we could use the multi-payer data set for measuring morbidity outcomes at the level of the local health department. So again, we created these sets of outcomes and morbidities using the claims data from our state-based resource. And similar to the mortality analysis, we used the NACHO data for the local health department capacity measures. And then we added in some rich sets of county-level covariates from the area resource file. So the first question that we needed to address is that question of the sampling frame, and we needed to be confident that our measure, our novel state claims database, was actually getting at a jurisdictional denominator. So we created a synthetic population using the census data and the enrollment, the denominator and enrollment data in the claims, to make sure that we could be confident about the missed pockets of patients. And so we were able to identify those missed pockets of potential population in the LHDs and infer the rate for those pockets. We could identify, enumerate them, and infer a synthetic rate. And then once we were able to do that, we needed to test that synthetic population. And so what we did is we took our morbidity measure from the claims and we tested that against the state inpatient data or the hospital discharge data. And we found very high correlations from our claims-based morbidity measure of 0.94 for influenza and 0.80 for heart disease. And this was not unexpected that they were lower than the inpatient data because we were never in our synthetic population able to enumerate the uninsured rate, and we also did not incorporate multiple hospitalizations. So once we felt confident we could enumerate that denominator and get a morbidity rate, we went through the process of identifying these ICD-9 code sets to define the measures. And so the preventive service rate per thousand population was calculated for each LHD for breast cancer testing, colorectal cancer testing, cervical cancer testing, and reportable diseases, which included flu and STDs. It also includes vaccine preventable diseases and foodborne illnesses as well. And then we also calculated from only the inpatient setting the hospitalization rate per 1,000 for heart disease, flu and pneumonia, and cancer. And we measured these rates at both time points, 2005 and 2008, and the change for each LHD. And we followed the same multi-level model that we had followed with mortality and found small but significant associations observed with our morbidity outcomes with local health department spending, staffing, and services. Specifically, we found that breast and cervical cancer testing, hospitalizations for heart disease, and reportable diseases all were associated with LHD capacity measures. The hospitalizations for heart disease was the only measure that we did find associated with spending, and when we interpreted that as we did for infant mortality, we found on average an increase in 1% spending across the LHDs would result in 91 fewer hospitalizations. We found significant associations with primary care services delivered by the LHDs, specifically with breast and colon testing, as well as the reportable diseases. And we also found that regulatory and licensing facility services were associated with decreased reportable diseases. So the next thing we wanted to really pilot and look at was that last methods challenge that I talked about with regard to the independence of observations. So we wanted to apply a geospatial approach to understand the contextual variables that we understand are shared between LHDs, because the LHDs are not necessarily independent. And geographers refer to this as Tobler's law, which is that everything is related to everything else, but near things are more related than distant things. And so in this data and in the context of public health services, we can measure that proximity and we can measure those distances and incorporate that into our modeling strategy to address that lack of independence and see how that impacts the return on investment or outcomes. So we did this through a combination of what's called LISA mapping and geospatial modeling. So LISA maps are from geography and a way to identify clusters and high and low rates of disease given the neighboring context of disease. But this approach is only univariate, so we have to turn to a regression model, a spatial lag model, that can help us identify the magnitude of that sharing effect between local health departments and which of those contextual variables are actually shared. So, excuse me, to pilot this, we took cross-sectional 2008 data for the rate of hospitalizations for heart disease. And when we just crudely map that using GIS, we might come to some conclusion about high rates of the disease or the outcome being in the far east and western parts of the state. But once we take into the context of the neighboring rates of disease with the LISA mapping, we come to a somewhat different story in that there's two very significant types of clusters in the state. One area that's high rates of disease, given that the areas around those areas are high, and low areas of disease, even given that the area around those neighboring LHDs are low. But again, that's univariate. It doesn't tell us what are the contextual variables describing that high morbidity. So we applied a spatial lag model, and that demonstrated that the rate of hospitalizations for heart disease between an LHD and that of its neighbors was in fact related. And this was even after controlling for contextual variables. So controlling for all the neighborhood context, the rate of morbidity in one LHD is tied and affects the rate of morbidity in the neighboring LHD. And of those contextual variables, we found some that were very significantly associated with the outcome. Specifically, higher rates of disease were associated with the percent of the non-white population, the percent of the population over 65, the number of hospital beds, and medical treatment services delivered by an LHD. And we found lower rates of disease were associated with increasing percent of population with college degrees and urban LHDs. We did not find the cross-sectional association with spending in this spatial model. But in conclusion, we really felt that the linked data resource can potentially provide valid measures of disease morbidity. And GIS mapping, which has been used in many areas of public health, but for systems and services can potentially identify significant variation in clustering of disease outcomes. But we have to turn to spatial regression modeling to really identify those important contextual variables and to quantify that sharing effect between LHDs. By combining the data and methods approaches, we can better explore some of these challenging constructs, such as contextual variables and time, and figure out how to maximize return on investment and economies of scale. Although we were trying to address some novel methods in some innovative ways, we still had some challenges we could not overcome. The nature data for our main exposures are all self-report, and so they had unknown validity and reliability, so we couldn't incorporate that uncertainty. The funding for health services are provided we found was highly variable across our LHDs, and we had an imperfect crosswalk between those categorizations at the local level. And we also knew that we were still missing events. ICD-9 code sets are notoriously difficult to construct, and although we used as many published code sets as we could and validated, we had to come up with several of our own. And we were never able to really be confident about developing a synthetic estimate for the uninsured in each of those LHDs. We were always dealing with a small sample size of up to 85 health departments, and although we tried to apply the same methods, we were unable to identify an instrumental variable as previously used by Dr. Mays. But for the implications for public health systems, I think in the era of increasing fiscal pressures, we need to better understand the context in order to maximize return on investments. And the best way to do this potentially is to capitalize on data infrastructure developments and not reinvent the wheel. And public health can actually be a really critical and important partner because public health departments and public health systems are actually really critical sources of data that are not found in some of these large data infrastructures that are being developed by healthcare systems or administrative systems. And these are populations and data about patients that are incredibly vulnerable and may not be well observed in other data sets. And public health practitioners have incredible context with regard to understanding the interplay and the correlations between these covariates and how they understand what they're doing may be affecting their neighbors. And it's really crucial, I think, to continue partnering with multidisciplinary stakeholders to really develop interdisciplinary methods. So we used methods from geography, but methods from econ and computer science and demography, I think, can really help play a role with leveraging some of these new data resources. And with that, we wanted to close with several of the research briefs and products that demonstrated the steps of this project. They can be found on the North Carolina Institute for Public Health website here. The publication describing the infant mortality in our mortality study was published this summer in AJPH, and we're in the process of finalizing additional publications that describe the geospatial methods, as I talked about, and our metrics for morbidity and outcome. And we're continuing to look for partner states with comparable data to further the development of more proximal outcome measures and hopefully increase sample size in the future. And with that, we really want to say thank you and recognize the Robert Wood Johnson Foundation, without which the grant funding, we never would have been able to even try this research. We have to thank the Lineberger Cancer Center in the state of North Carolina for developing that large novel database. We had great feedback and collaboration throughout the project from the North Carolina Public Health Association, the Academic Practice-Based Research Section, and last but not least, we really are grateful to NACCHO for the use of their survey data of local health departments. That's a really crucial resource for this field. And with that, we're a multidisciplinary team trying to pilot this work. And thank you for listening.
Thank you, Anna. Thank you, Anne-Marie. To give some commentary is Dr. Michael Stoto, who is a professor of health systems administration and population health in the School of Nursing and Health Studies at Georgetown University. Michael is a statistician, epidemiologist, and a health services researcher. His substantive research interests include public health practice, particularly emergency preparedness, drug and vaccine safety, infectious disease policy, and ethical issues in research and public health practice. Prior to joining Georgetown, Dr. Stoto was a senior statistician at the RAND Corporation and associate director for public health in the Center for Domestic and International Health Security. Dr. Stoto is also an adjunct professor of biostatistics at the Harvard School of Public Health. He is a recognized expert on population health and public health assessment, where his work includes systems-oriented evaluations of public health surveillance systems at the local to global level, addressing both statistical methods and public health practice issues. Dr. Stoto has developed methods for evaluating community health assessments and performance measures and worked with state and local health departments, especially in Washington, D.C. metropolitan area, to implement these methods. Michael is an expert in public health systems research, focusing on applying and developing rigorous mixed methods approaches to studying and evaluating federal, state, and local public health systems. His recent PHSR work focused on public health emergency preparedness, regionalized public health services, and methods for the development for emergency preparedness capability assessments based on exercises and actual events. So with that, I'd like to turn it over to you, Michael.
Okay, well, CB, thank you very much, and thanks especially to Anna and Anne-Marie for that great presentation. Really a tremendous amount of work has gone into that, a very sophisticated data analysis, and also all the work that went into gathering and managing the data and dealing with some of the challenges that Anna and Anne-Marie mentioned. So I think it was really very an impressive amount of work and an interesting presentation of it. But when you think about what were the results, and I'm focusing here especially on the first part of the analysis, but I'm not sure that the second part changed it all that fundamentally, is that overall spending was not associated with any of the mortality outcomes that they looked at, and that when they looked at staffing and the provision of medical treatment services, these were associated with decreased infant mortality, especially prenatal care and obstetrical care. Isn't that just what you'd expect? So let me think about that a little bit. And I think the issue is that when you focus on the outcomes that were most likely to be associated with the intervention, so particularly linking infant mortality as an outcome to prenatal care and obstetrical care, that is the way that you are most likely to see an intervention. It's kind of like when you design a randomized clinical trial, you try to identify the patients and the circumstances under which it's most likely to work, at least to establish efficacy and deal with effectiveness later. And this called to mind two different things that have been, one that's been in the news lately and another one. The first one is this study by Ann Case, Professor Ann Case at Princeton, and her co-author, who happened to win the Nobel Prize just before the paper was published, looking at morbidity and mortality in midlife in white non-Hispanic Americans. What they did, and the real power of their analysis, was they broke out the mortality data by specific causes, here focusing on poisoning, suicides, and chronic liver disease associated with alcoholism, and poisonings have to do with drug overdoses. And they compared that to other causes like diabetes that have been going up, that have been flat a little bit and maybe only going up a slight amount in the last couple of years, and for lung cancer, which actually has been going down. And then when they focused in on particular age groups for these same three causes, they found a stronger rise at age 45 to 59 and a flatter slope for other ages in the adult age range. And based on that analysis, by focusing on the right aspects of mortality in the right populations, they were able to construct a case essentially about how this large group of Americans was left behind in changes in the economy. Another one that I've been following more carefully is the work done by Ben Summers and others at Harvard, published last year, looking at changes in mortality after healthcare reform in Massachusetts back in 2006, which of course was a model for the Affordable Care Act. And what they did is they focused on the specific causes of death that are known to be more amenable to health care as opposed to other causes of death. And by comparing Massachusetts to matched control counties in other states, they found a significant decrease in the period immediately after the intervention took place. So the point here again is that when you focus on the interventions that are most likely to be associated, the outcomes most likely to be associated with the intervention, you're most likely to see an effect. So what I would ask, coming back to North Carolina analysis, is I wonder whether the same thing would be true. For instance, if we looked specifically at the provision of colorectal cancer tests and colorectal cancer either incidence or mortality after an appropriate time lag. So why is this important? I think it's important for two things. First, methodologically, that's how you find the most likely to find an effect and to be able to establish a cause and effect relationship. But practically speaking, local health officials generally have very little control over their department's total budget. They do, however, have more influence over the spending and the staffing on particular services, either by reallocating available funds when that's possible, and of course that's not always possible, by applying for external funds, federal funds, grant funds from foundations, and so on. And maybe even most likely to collaborate with local healthcare providers that are engaged in value-based purchasing. One of our medical students here at Georgetown has been working with the state health department in Colorado that's been trying to identify ways that local health departments can work with providers in their counties to actually provide services more efficiently to their patients. And of course, community health needs assessments are a national approach that's really trying to bring these health departments and hospitals and others together to collaborate. And it may be that health departments, with the kind of evidence that Anna and Anne-Marie told us about, and especially with what Anne-Marie was saying about how health departments can bring data to those collaborations. That's the kind of leverage, I think, that can help, that will allow local health officers to really leverage some of the other activities in the community to really make a difference in population health. So I think I'll stop there, and now we'll hear from a practitioner.
Thank you very much, Michael. And as a reminder to the audience, please start typing in your questions in the chat box, and we will have Anna and Anne-Marie answer those at the end of the response to the comment. So our next commentator will not be able to join us, but Anna will be reading his comments, is Mr. Leighton Long, who is Public Health Director for the Chatham County Health Department in Pittsboro, North Carolina. Mr. Long has worked in the public health field since 1988, including the Environmental Health Services of Union, Transylvania, and Buncombe County Health Departments. He has also served as State Environmental Health Director in North Carolina's Department of Health and Human Services and Health Director for Davidson County. Mr. Long earned degrees from the Central Michigan University and North Carolina Wesleyan College, and also served 4 years in the United States Air Force. So with that, Anna, I think I'll turn it over to you so you could go over his comments.
Thank you. I know that Leighton wishes he could be here. It just so happened he had a conflict for this particular hour, but we went, he worked with us all along on this project, but he also took a step back and provided us with some written comments. And I'm going to try to just summarize the gist of what he was saying in this slide right here. So the first point that he wanted to make is that, yes, health departments are increasingly expected to justify the services that are provided. And he went into quite a bit of detail about not just justify what they provided, but from the perspective of a local health department to understand if what they are provided is needed and is actually doing what needs to be done. Because from the local perspective, there's plenty to be done out there in the field, and they need to be able to know that what they're doing is effective. So one of the things that he thought was important is that the message get out that more research is needed for these proximal outcomes. Health departments can't wait years to understand whether or not their mortality rates have changed. They really need more proximal outcomes, and not everything they work on is a mortality outcome. So he was excited about the idea of using claims-based measures, but would also encourage the development of other types of measures from claims or clinical data that could help local health departments target and justify and understand the value of their services. So the second point that he wanted to make is that health departments should be looking to maximize available resources through partnering with hospitals, nonprofits, and academia. And this is actually what we were just discussing, what Dr. Stoto said in terms of working collaboratively with hospitals. This is a community contains a number of organizations and agencies within it, institutions, that need to be collaborating and pulling their resources and data together. The third point that he made is that health departments need to assess the services that are being provided. And one of the issues about this is that a lot of programs get institutionalized, and his feeling was that we continue to offer the same programs without taking a careful look at whether or not they're actually achieving the outcomes that are desired. But also, if you look at that, a single health department can do that on their own, but sometimes they would run into small numbers, or they might not have the capacity. So that thought in this discussion point was that he felt like there should be collaboration across jurisdictions, and this is where academics can become valued partners, because if we can play a role in looking across jurisdictions at whether or not the services that are providing are achieving the intended outcomes. And then finally, he put in a plug for for local data, as was mentioned earlier, community health assessments are important, but oftentimes those data are either old or perhaps they need to rely sometimes on synthetic estimates, and they're not or they might be mortality data, and they don't have the proximal outcomes they need. And so again, a plug was made for improved methods and better data, with a comment made that, the better data we have at the local level, then the better decisions we can make.
Thank you, Anna. So with that, before we open the webinar to questions from the audience, I'd like to give Anna and Anne-Marie time to respond to the comments from Dr. Stoto or from Leighton. And so go ahead. You have the floor.
Okay, thanks. Well, I'll start off, and I think Anne-Marie can jump in at any point, because we really do see this as a conversation. So thank you, Dr. Stoto, for those comments. And I think you're right on point. In fact, you've helped us several times in the past sort of see the point that, yes, the devil is in the details. When we talk about spending, that's a big thing. Or we talk about programs and services, that is a big thing. It means nothing until you drill down and begin to understand it. And if you don't drill down, you won't see. If you look at things at too macro a level, you cannot see the nuances in the data. So when we looked at infant mortality, specifically saw those strong relationships with services that were expected to affect infant mortality, that was when we knew we were on the right track, and that it all made sense. It really doesn't make sense to expect a large budget in the aggregate per se, not knowing what services are provided, to affect something like infant mortality. So thank you for clarifying and showing other examples of where it's important to drill down, because we agree with that.
Yeah. And I'm really glad that you brought up the Case and Deaton paper. I think it's a fascinating paper, as well as Summers. The challenge, those papers are great, and the previous work done by Dr. Mays has been really, really informative with regard to measuring a hard outcomes. But the challenge with the mortality, even, and I see some of the questions there saying, mortality is this long effect. You wouldn't expect an immediate. And even in the analyses previously done that have shown associations with spending and mortality, we had to look at this in a very robust way, because specifically instrumental variables were what, at the application of those economic methods, were what brought that finding out and found that significance and that association, a way to control for the unmeasured confounding, because we don't have good measures in some cases on all the variables at all the time points and that we would need. So it goes back to mortality is so critical, and we see these trends that are striking, but to really unpack them in the details, we need to go back to, okay, we want to understand what the levers are to change these increases in incidence. What data do we need, and how do we need to model it in the way that it makes the most sense, given the limitations of the data that we could find?
Can I respond briefly to that? This is Mike. I mean, I think it's a good point that I saw someone raise the issue about the lag for mortality rates for some things in the chat. And in addition to what Anne-Marie just said, there's another way to think about that, which is that for something like lung cancer as the outcome, no, it doesn't make sense to look at lung cancer immediately, and of course you can't wait 20 years. But what you can look at is smoking, because we know pretty well that changes in smoking behavior will have the desired effect in the long run. So if we can measure the impact of health department and other community activities on the smoking rate, we don't need to worry about the cancer and the heart disease consequences that go along with it.
Totally agree, and I should have added, we are actually talking with our state partners about breast cancer and cervical cancer screening and looking at the data, the linked data to look at pockets of, low rates of screening, high morbidity, late stage diagnoses, and mortality. The challenge, again, just to bring that home with smoking, for example, we actually wanted to integrate some BRFSS data, but again, the challenge of that denominator and enumerating that denominator and having the observations available for, so you have to have smoking measured on everybody in a set population. And that's really challenging because local health departments aren't necessarily collecting, they don't have the capacity to collect this data. And some of the available data out there are either strata sampled or sampled in a way that aren't available or aren't on the time that you have the other measures on. And so it's kind of like piecing the puzzle together. But we are actively trying to tease a little bit more into specific services with regard to things like diagnoses or late stage and things like that.
Thank you, Anne-Marie. So I think we have a few minutes for questions, and not only for Dr. Schenck or Dr. Meyer, but Dr. Soto, please feel free to chime in too as well. I guess there's related questions or comments from JP and Lava about, maybe using NACCHO, the NACCHO survey reports from beyond 2008, since the recession didn't really hit until after that. Any comments to respond to that?
Sure, this is Anna. I'll respond to that. We agree. I saw those comments come up, and I couldn't agree more. But whenever you put together a study, you're limited by the data that are available at the time. So one of the things we were trying to do is align everything properly. So we saw the measures on spending as needing to come before the data on outcomes, just getting the temporality right. And we were limited on our outcome data to 2010. So at the time we conducted the study, there was a later NACCHO profile, but we didn't have any claims data that followed it. So, we agreed that it would have been better to have done that, which is why we went to the trouble to see if we were seeing some of the recession hit. We were, but in the aggregate, the spending was increased. The ability to measure those associations was not changed. We could still proceed with that analyses, and then the second part of our study was to develop the method. So we felt like there still had value, even though we knew we would miss the the major brunt of the recession. But you're absolutely right. We agree with that comment.
I think Dr. Soto spoke a little to something about what Gary was asking about, mortality and how these chronic diseases take years to develop. Would you like to add anything more to what Dr. Soto said, to what Gary was sort of commenting on?
Just to reiterate that, one thing about infant mortality is that it is something you could expect to see a difference in a short period of time. It is not like the other chronic disease mortalities. And so we knew we had a short window. In the great work that was done before by Mays and Smith, there was a much longer time window where you had time to observe differences in mortality. We had a 5-year period, so we really did not expect to see differences in mortality linked with these services and spending and outcome services and programs. But if we were going to see it, we did expect that it would be in something like infant mortality, where there are services and programs that can be offered in a very short window before pregnancy and after pregnancy to reduce infant mortality.
And in our morbidity measures, we did see things that are very proximal, like regulatory and licensing. So this includes, in North Carolina, we have restaurant inspections. And so these are things that have very acute effects with regard to things. You could study vaccine preventable diseases, and you can look at coverage of vaccines, and then you can look at hospitalization for vaccine preventable diseases, and you look at programs and outreach. And these are very acute services that should have within the year an appreciable effect. You know, and again, by being able to look at the outreach and the degree to which different LHDs, that variation in sharing, there's ways to kind of tease out that effectiveness and that excess change or morbidity associated with that. So, you know, we all agree about the mortality and even the chronic disease morbidity, but there are things that local health departments are doing every day that have potentially acute impact. And even things like diagnosis or the late stage diagnoses of cancer with screening programs. I mean, that cancer may have been latent and we're not talking about prevention, but we're talking about screening that get them at earlier and more treatable stages. So these methods and this data, I think, is sort of proving proof of concept for that ability to identify more acute and proximal morbidity service relationships.
I think we have some time for one more question, and I think just taking Lava's question and comments, I think just taking the big picture thing, view of things from your study, how are these results now being used, I guess, on the practice side and, you know, in helping LHDs, maybe North Carolina pursue efforts to enhance the quality of their performance, given their limited public health, you know, fiscal resources and constraints, and the changing or challenging economic environment, and, you know, with the ACA passage too as well. So I guess sort of a wrap-up, big picture view from both of you.
Well, this is Anna. I'll start. So in terms of big picture view, well, we were able, and it wasn't solely, we can't take sole responsibility for this, but our legislature, even despite the fact that we have not expanded Medicaid and we were not living in a time in an era when budgets were likely to be expanded, we were asked to come and present to a legislative committee, appropriations committee, a joint appropriations committee, about two things: where North Carolina stands in relation to a number of areas, but in particular in relation to children's and infant mortality and children's health. And the outcome of that was actually additional monies for infant mortality. So we like to think we had a small part in that, but it also is the door being open and the opportunity. So now the money has been allocated. It is recurring money. The onus is on us to be sure we can demonstrate that when you put money at a problem, the local health departments can use it to actually address it and achieve the outcomes that need to be achieved.
Yeah, and this is Anne Marie. I think the LHDs, my hat is off to all the practice folks out there, because I think it is a really challenging environment, especially with the ACA. And I think in looking at the data and the experience over this project, I think one thing is really critical is that the recognition of that sharing and those relationships, that there needs to be a constant relationship checking in about services that are being provided and making sure that economies of scale and not duplication of effort. And I think historically the local health departments, you know, all know each other, but as someone pointed out, this ACA and reaching beyond our traditional partners and reaching out to the hospitals and to the other healthcare service delivery organizations and figuring out how to combine and maximize, and I mean in services, but also in sharing data and evaluation and a feedback loop.
Well, so with that, thank you so much, Dr. Schenck and Dr. Meyer and Dr. Stoto, for the presentation and the comments. And we would like to just quickly, before we let everyone go, announce that the 2015 call for proposals from S4A is now available. We invite you to take a look at it. Please take note of the dates that there will be an informational webinar on December 18, 2015, and also the letters of intent will be due on January 12th. So we encourage you, feel free to share also this link with your friends. We're trying to get as much hits as possible. And also, we'd like to, again, invite everyone who's on this webinar to also look up our upcoming webinars and take note of that. Today's webinars and past webinars are also available for download. If you check out our website in the archives, these are also available. And again, we'd like to thank our presenters, Dr. Schenck and Dr. Meyer, and also our commentator, Dr. Stoto and Leighton, for their comments too as well. And thank you everyone for joining us today's webinar, and we hope you have a great day. See you soon again. Bye.
Bye.
Thank you.
Thank you.